Good evening, everyone, and welcome to now the 24th monthly webinar with Dr. Imran Lasker. Um, I hope everyone had a great bank holiday weekend. And today, Dr. Imran will be looking through quite a range of cases. So we've got some plain film x-rays, some chest x-rays, and a few CT cases as well. I'll be posting the collection in the chat box so you can follow along throughout the webinar. Anyone that can't access it via the link, please reach out in the chat box, or you can also email us at support@cmrad.com and I'll be able to give you access. There'll also be some poll questions throughout the webinar. Those will just pop up. Feel free to answer those questions and then Imran will reveal what's correct as well. There will also be a CPD certificate at the end of this webinar. All you need to do is just fill in a short feedback. Once that feedback is completed, we can generate that certificate over the next day or so. And I think that's everything. So with no further ado, I'll pass you over to Dr. Imran Lasker.
So hi everyone, hope everyone is well. Thank you so much for coming to this webinar. So hopefully we'll be putting the link for all the cases up in just a minute. I'm going to share my screen as well. So let me just share desktop too. Here we go. There we go. And then make sure I've got the Q&A open and the chat function open as well, so I can try and make sure that I can keep up with any of the questions. So so my name is Dr. Lasker. Thank you so much for turning up the 24th one. So that's like, what, 2 years of this, which has been really good fun. I hope it continues to be useful for everyone. I think we did miss a couple during, I think, early in the year because my daughter wasn't particularly well, but she's doing really well now. So things are going great from that side of things. For those that don't know, we're just going to go through a few cases on Collective Minds, the platform that I personally use to do a lot of my teaching and run a lot of our courses at radiologyseminars.co.uk if you are interested in any courses at all. So we have the link now. So we just have a look at case number one. And I think a question will come up as well, like a little kind of a little poll. So let's have a look at this one. And we're just going to work through all this together and just try and figure out what is going on with the patient and what the issue could be. So I guess at first you may think to yourself, well, it's a young patient. It looked kind of normal to me. So there's nothing really to worry about, right? But actually, this doesn't look quite normal because yeah, it's a young patient, but you can see a kind of growth plate, but then you don't really see much of anything else. Like I can see a growth plate there, and then you can kind of just see the distal radius over there as well. So you think to yourself, like, well, okay, maybe this is really young, maybe that's what it is. But if I told you this patient had a failure to thrive, then you got to start worrying that, okay, they've got failure to thrive. And actually, when you look at these bones, they do feel like they're kind of splaying as slightly outwards, don't they? Don't look quite right. Yeah, they don't look completely normal. The ends don't look particularly great. And actually, in some level, you could say that, what did someone say? Yes, I say metaphysical splaying. So you can also see a little bit of what looks like a bit of a cup. You know, they look like they could literally hold a whole load of water within the area as well. So that's not quite right either. Fraying as well. Like maybe you could say this. I mean, the bones themselves don't look great, and actually, when you zoom in a bit, you almost feel like the cortex isn't particularly well defined either. So when you kind of I think someone's got it here, but when you look at this, you have to start thinking about sort of the metabolics or developmental issues that can happen. And thankfully, we don't see too much of this these days, but this is something known as rickets, which is secondary to vitamin D deficiency. And it looks like, yeah, I mean, most of you guys have got that one. So don't worry. I know some of you might be like, oh, God, that's like a really, really easy case. Don't worry. The cases do get more interesting, I hope, and a little bit more difficult as we go forward through the rest of the talk. Okay, so that's number one, a nice little plain film thrown out the way. So 84% of us said it was a lack of vitamin D. So well done. That's hopefully quite good. And almost like I'd say a textbook case, wasn't it? Like quite a nice, well, it's not a nice case for the patient, but very, very nice for us. So there we go. We share the results and go to the next case. So what we'll do is go to the plain film first, because I always think that's a good thing to do. So yeah, share results. That's nice. And then do this and come up to here. Okay, so what we have here is a chest X-ray. Okay, and so first off, unlike the other person, this one looks like an older patient. This looks like we can see fused growth plates. We don't see growth plates anywhere at all. Okay, I'm going to get rid of that again. And then we just do what I normally would do is have a look at the lungs, make sure that the lungs are okay. So the lungs look relatively clear at first glance. I don't see anything grossly abnormal. Then you look at the costophrenic angles as well, just make sure that they are nice and clean. So they look very, very sharp. Don't think there's anything grossly abnormal there. Okay, good. So then look at the lung apices. So it's really, really important. You do have a good look at lung apices. And I always say, draw a little square like this, draw a little square like this, just to make sure there's no pneumothorax sitting there whatsoever. But yeah, there's no pneumothorax that we can see here either. Okay, so good. So then what we'll do is have a look at the hilar region. So that's your one hilar there. Looks very, very sharp. But this one looks like there's a sharp hilar, but it looks like there's some added density located there. So, okay, that's something to bank in the back of your head that, yeah, things aren't quite normal. Look at the lung and look at behind the heart as well. And that's a very, very important area as well. And behind the heart looks okay as well. So we're not particularly worried about behind the heart. So the only real abnormality we've seen here is this one. So by the way, if you are interested, this is a really good presenting tool you can use. I'll do fading arrows. So you can see this little thing over here. This is the abnormality that we're looking at. This doesn't look quite right. So is it the aortic knuckle, right? So we know the aortic knuckle is probably this one here. And the other thing that tells us is most likely to be the aortic knuckle is you can see a bit of calcification located on the outer aspect, and you can get atherosclerosis involving the aorta, and that can be seen over here. So the aorta looks like it's kind of sort of doing this and then diving down to the breast of the chest. So this looks very, very kind of different, doesn't look quite right. So let's zoom in. Someone wants a lateral view, don't have a lateral view, sorry. But what we'll try and do is just try and think about where this actually is. So you've got the hilum, and it looks like it's quite well defined. So it doesn't look like it's coming from the hilum, because otherwise you probably have a bit of splaying, a bit of increased density, wouldn't look so sharp. So is it posterior? So, I mean, it could be posterior, but it can't be that far posterior if it's going to be posterior at all. Because first off, you can see that the ribs don't look like they're splaying outwards, and you can actually see the aortic arch going through it. So it doesn't look like it's really, really far back. So your options are, it's probably not going to be posterior, right at the back. It's not be in the middle mediastinum, because, you know, the higher looks okay. Doesn't look like there's much in the way of any, and it doesn't look like it's uniform with the hilum completely. But then, therefore, maybe anterior mediastinum. And so that's something that we may need to think about. Right. So then what we'll do, we'll go across to the CT scan. And what I'll do is press this download button, which is really useful because it just makes the images download onto your local platform really easily. And don't worry, it won't be saved on your hard drive or anything, but you'll be able to sort of scroll through the images a little bit easier. So while that red line goes across, we just have a quick look at the CT scan. So again, we can see it's an adult patient. And there's contrast sitting within this adult patient as well. So there's contrast located here, contrast located over here, and contrast located over here. So, okay, so what we're going to try and do is kind of scroll through and see if we can find this abnormality. Does it pop up at all anywhere? So come from all the way to the top, scroll down, scroll down, scroll down. I always tell everyone to always do one scroll through, like whatever it is, you may see something, keep scrolling, keep scrolling, keep scrolling, all the way to the very end. All right. So just keep doing that, because otherwise you may miss something that's really, really important. And the reason why I think is really important to do that is because there has been occasions where, let's say you get stuck all the way up here and think, oh, you know, there's some weird abnormality here. You start looking it up, you're doing typing, you're talking to a mate, like, what's that? Meanwhile, they've got some massive dissection sitting out here and they're hosing blood and all sorts of terrible things are happening. So it is really, really important that whenever you look at any sort of scan, you always, always, always scroll through all the way to the very end and then come back to whatever abnormality you think you've seen. Okay. So I think all of us have seen this abnormality here, and I think that's why someone wanted to get the lateral view, because they were trying to figure out where this actually is the anterior middle or posterior mediastinum. Oh, so I just wanted to go back to this one. So someone has described it as a round opacity, well-defined left hilum. Exactly. These are all the describing words that you want to use when reporting this. If any of you guys are doing exams or anything like that, then that is definitely the way to describe it. And if I was doing an exam, I would say something like this: as an adult PHS film, we can see that there's a round opacity located where the left hilum, it is well defined, doesn't have any spiculated regions. The surrounding lung parenchyma looks okay. No splaying of the ribs, doesn't look like it's uniform with the hilar region. The hilar region looks okay. So I'd probably put this in the region of the anterior mediastinum. I would therefore get a CT scan for further characterization. My differentials would still potentially be lymphadenopathy, a potential malignancy, and that's what I'd be doing the CT scan for further stage and looking for any further involvement anywhere else in the body. And then you get your CT scan in an exam situation. And now we've seen this lesion that's located here. Okay, someone wants lung window. So if you are on this platform, do use the lung windows and have a look. So if you scroll through and just see what you think it is. So, sorry, hang on, let me just. Okay, so let's scroll through from the very, very top. So very, very top. So that's just because you, with your lungs, as you get older, I suspect there's not as much blood flow to the apices, and so you can get a little bit of apical scarring. You've got a bit of like emphysema, which is sort of subpleural emphysema, isn't it? Just along the edges there. Coming further down, someone says, are there any other nodules anywhere else? So we'll try and look and make sure we haven't seen anything else going on. Apart from that lesion, yeah, there's a bit of these linear opacities going across here and across here. So you could say there's a bit of there are a few bands of atelectasis. Now, what you can do on this platform is, I think is it this one? So if you go, there was a way to MIP. I can't remember how to do it. Was it Mr. Bleak or something? Yeah, I think this is the way to do it. So then what you need to do is go layout one. Oops, layout one. Then you've got this, and then you can go MIP, and then you can sort of increase your thickness of the MIP, and then you kind of got that Christmas tree looking like thing, which is really, really cool. And that helps you identify whether there are any other nodules anywhere else. So let's scroll through. Oops, let's go right to the top. Come down, come down, come down. Let's see if we can find any more nodules. Kind of gone a bit blurry. Maybe I did too much of a MIP. Good. Let's go like to 10. Scroll through. I mean, you could say there could be a tiny little nodule there, but it's so small, isn't it? Really, really small. Maybe potential one that's kind of somewhere here, but it's very, very small as well. So nothing major to really kind of get too worried about. Okay, so now we've got to come, let's come back to this lesion. We've got to try and figure out what's going on, right? So we have got this lesion and it's very well circumscribed. And then when you look at the lung windows, we can't see. So if you want to do lung windows, go to like number 4 and just scroll through, and you can see the lungs generally look okay. It doesn't look like there's any sort of spiculation along the outside. It doesn't look like it's invading anything. It actually looks like it's pushing things away, right? So when you look at that vessel, look at that pulmonary vessel is there, kind of caving its way around this lesion. Okay, so that's one of the things that we've noticed. That this is probably going to be something that is been there for a long, long time. Okay, that's definitely the case. And actually, there's a bit of hyperdensity located within there. So if we go to bone windows, look at that. It looks like a calcification located within that region as well. Okay, so then someone said, could it be a teratoma? So generally speaking, we'd say teratomas are going to be the anterior mediastinum, going to be quite aggressive, and you probably get a bit of soft tissue reaction, a bit of swelling, and all that kind of thing. But this one looks very well circumscribed, and there is a bit of fat density located within here as well. So what we'd probably say is, yeah, exactly right. So this is actually in keeping with a pulmonary hematoma and is not something to worry about. You can probably leave that alone. And I think actually what it was is that this patient came in with an X-ray for chest pain, got a CTPA for chest pain, and this is just a finding that was there anyway on top of everything else. So actually, when you look at the lungs, I think the rest of the lungs are okay, look okay. And oh yeah, so by the way, I know some of you guys are registrars or just still learning and stuff. So what I do when you're looking for PEs, if you don't do this already, is do a MIP. It's really, really useful because it just makes things slightly easier to go to about 10, keep it on these kind of windows, maybe slightly, maybe make it slightly, oops, there's a window, it's slightly to be like this. And when it looks like a tree, it just makes it a little bit easier to see if there's like a sudden abrupt cutoff of any of these vessels. But I haven't seen anything grossly abnormal here. So you kind of scroll through, scroll through, scroll through, make sure you haven't seen anything grossly abnormal. And then it is quite worth going to the coronal views as well and just doing the same thing. Because it just having a look at different views can be really, really useful. You're thinking incidental lung embolism, right lower lobe. Okay, I hope not. Let's see. Right lower lobe. Image. How did you get images? Do I not have the information? Okay, he said 202. Let's have a look. 202, and you think there could be. Yeah, there is. Yeah, yeah, yeah. Okay, I forgot about that. Yeah, so there is looks like a P located within this region. Good spot. A while since I last saw this one. Okay, so yeah, I'm going to show that to everyone as well. So you kind of scroll down. What you've got to do is make sure, the other thing to do is always make sure that this follows onto a pulmonary vessel. And actually, in this case, this does, doesn't it? You follow that down all day long. Like, so yeah. So they do actually have a really small pulmonary embolism. So we're very, very well caught on. So I'm going to do one confession. I thought we were doing the talk yesterday. And so I frantically got all my cases ready and then sort of just pulled it together and then left it at that. So my apologies, but yeah, there is actually PE in that on top of the hematoma. Okay, cool. Let's have a look at this one. So this is a CT head of an adult patient. They've come in with a acute headache. So let's scroll through and see what's going on with this one. Okay, so just got to wait for that to download. So what we can see here is, okay, so not a bad shout. Good, good. I mean, it's not a thinking. So let's have a look. Anyone else come up with any ideas? So someone has gone for pneumocephalus. So let's scroll through. I can see why. As you scroll through, you keep scrolling, keep scrolling, you keep scrolling through and come all the way to the bottom. So always do it all the way to the bottom, all the way to the bottom. Okay, good. So we've done that. Let's scroll all the way back to the top. And then, so someone said they thought they could see some air. So these black areas here. So yeah, that looks like black, black. And that looks very, very black as well. So you would be thinking, okay, this could be air. I mean, this could be air. So that could be pneumocephalus. Pneumocephalus could happen for plenty of reasons. Actually, I saw one pneumocephalus because someone was doing a lung biopsy, and I think they must have hit like a thoracic vessel or something. And then like they end up having like an air embolus going all the way up into their head. But this one, if we go to lung windows, it doesn't quite look the same as air, right? Because it kind of, yeah, I'll give it to you. It does look a bit sort of almost as dark, but it slightly has a sort of dirty appearance to it. And as you come further down, this area of air, quotation mark, doesn't look so airy at all. It looks like it's kind of got a bit of a soft tissue area to it, potentially even a calcification located there, potentially, and all kind of emanating from this region over here, the suprasellar fossa. So if we come back, scroll through again. When you come back to these areas of air, quotation mark go, they look very, very linear and particularly located within the subarachnoid spaces. So the air that you thought you saw in the subarachnoid spaces, yes, it could be under underlying pneumocephalus, but these are very, very much within the subarachnoid spaces. And when you've got that and this big lesion located within the region of the suprasellar cistern, this would be in keeping with a dermoid cyst. And that's exactly what you're seeing. It's a ruptured dermoid cyst. So for those that don't know, you can actually, some people can be walking around with a lesion in their head, don't even know about it. And this lesion normally would be around this area over here. And it's mostly fat, mostly it's going to be fat. And so what ends up happening is that you can get a rupture of that fat, and that fat because sort of dissipates and are all around the brain. And then it's known as a ruptured dermoid cyst. And then that is known as, I think it's like a chemical meningitis or something. So basically it results in inflammation. Oh, someone's got their hand raised. Yeah, if you've got your hand raised, I mean, you can type your question in on the thing. That might be easier if you want to. But yeah, so this is a ruptured dermoid cyst. And I think what they ended up doing was going transnasally to get this out. So the follow-up actually had like a whole load of nasal bones gone, but this was gone, eventually taken out. But yeah, component of dermoid cyst is cholesterol, not fat. Yeah, okay, yeah, fine, fair enough. Cholesterol. Is that not the same thing? Have I got that wrong all my entire life? Cholesterol and fat, are they not the same thing? I feel like I've been really silly now. Okay, fine. Let's move on to the next one. Okay, what is it then? Yeah, I'm going to look this up. You've actually got me very, very curious. Okay, right. So let's go to the next case, and I will make a mental note of looking that up. Okay, so we've got an abdo-pelvis. I'm going to have to go with abdo pain because, yeah, I suspect it to be abdo pain as it usually is. We're going to wait for this to download. And we are going to see, okay, let's have a look at this first. So this is an adult patient, first off, and we can see they've got contrast located within the aorta sitting over here, the IVC sitting over here. And then if we scroll to the top when we're ready, so we just got to wait for that red line to go all the way to the top. Okay, so heart is in the right place. I've been caught out by that once. Scrolling all the way down, scrolling all the way down. Keep coming down. Okay. So abdo pain, the one thing that I always do is kind of use a system. So I always try and think of a system. So things that can cause pain are going to be the gallbladder, but you've got a few calcified, hyperdense lesions over there. So that looks like it could be previous cholecystectomy. So I can bank that. It's probably not going to be cholecystitis. Intrahepatic ducts can be dilated post cholecystectomy and all the rest of it. But I mean, the CBD looks a bit large, but that's all within in keeping with a previous cholecystectomy. What else can cause pain in the abdomen? Pancreatitis. Yeah, pancreatitis could cause pain. Pancreas looks okay though. Let's look at the kidneys. Kidneys look okay there, and let's look at that kidney over there, and that looks okay as well. So kidneys look okay. Adrenals don't usually cause pain, but if I'm looking there anyway, I'll have a look. Good. Then we'll have a look at the spleen. Spleen looks okay, doesn't look like there's any laceration. So we're running out things that could be causing pain. So then what we need to do is go all the way and follow the rectum and come all the way back up. So we come all the way back up, all the way back up, go all the way back up, and just follow this round, okay? And this is a real skill, I think, over time. I'm not saying that I'm skillful. I've just done this a few times. And you can see the sigmoid colon going this way, and then you're kind of going this way, and just keep following my mouse, keep following my mouse. This is where I am. Keep coming, keep coming, keep coming, keep coming. So we're coming up to the descending colon. Then we're coming up to the splenic We're going all the way across transverse colon. Transverse colon looks okay. Across to the hepatic flexure, coming down, coming down. We're going down to the ascending colon. We've kind of veered off towards the midline. Okay, we're all the way down in the middle, unusual. And then you got this sort of fat thing over here. So that's going to be ileocecal valve. And then you can see that that must be the terminal ileum coming that way. So quite unusual, isn't it? Usually you have the cecal pole over here and you've got terminal ileum going this way. But this looks like, for whatever reason, cecal pole is all the way in the middle and the ileocecal valve is going out that way. But the ileocecal valve looks okay. Coming further down, oh, hang on, that doesn't look quite right. So it looks like a little finger, doesn't it? Kind of pointing at you like this, pointing out that way. So you can see that this is a cecal pole, right? So that must be the cecal pole. It's gone all the way down to the middle. You got your ileocecal valve, and you can tell that's ileocecal valve because of the fat of the ileocecal valve. And then further down, you've got this sort of blind ending loop, and this is inflamed as well. And if you guys don't see that, let's zoom in. And that's normal fat. And that's fat around here, which is look very, very hazy, very, very cloudy. And the wall looks very, very inflamed as well. So this would be in keeping with acute appendicitis. And so therefore this would be in keep. Yeah. And the other thing you want to be thinking about, is it perforation? Is it a perforation or is it a collection? And the way to do that is just to reset everything. So let's reset all and then come down to the lung windows. Just make sure there's no air anywhere inside the abdomen or the pelvis. So that looks good. Doesn't look like there's any perforation anywhere. And then, yeah, you want to have a closer look at there and just see if there's any sort of collection or anything like that. But it doesn't look like there's one there. And someone said, yeah, tubes are clipped as well. That's correct. So they've had their fallopian tubes clipped as well. I think it's related, but yeah, that's a secondary thing to be looking at as well. So yeah, so the reason why I thought this was interesting is because at first you're not entirely sure, but if you go to basic principle, just follow the bowel all the way around, find the ileocecal valve, then you should be able to find the appendix. And then once you find the appendix, you can see that actually, for whatever reason, the appendix is sitting right in the middle of the pelvis and looks very, very inflamed, but not perforated, which is also kind of good news for the patient. Okay, so Lex, well, yeah, you guys are pretty fast actually. Maybe your internet's better than mine, or you're just rapid. Okay, so let's have a look at this one. So this is another CT scan. Hopefully, I haven't doubled up and done the same scan twice. Let's have a look. So this is again a contrast enhanced CT. Looks like it's in portovenous phase. Looks like they're an adult from the first few images that we can see. So what I'll do, I'm going to scroll all the way to the top here. Hearts aimed in the right direction, which is always good. So we're not looking at situs versus something weird and random like that. And I'm going to just say it's going to be abdominal pain again. And let's have a look. Gallbladder. Okay, so unlike the last gallbladder, this gallbladder is here. No fat stranding around it. So we can't say that's going to be acute cholecystitis at the moment. We haven't seen the entire thing. Okay, we're almost at the end of it. Oops. Zoom in. Okay, good. So gallbladder looks okay, I think. So pancreas is this feathery thing sitting across the front like this, going all the way across to there. That looks okay. So we're not worried about the gallbladder, the pancreas. Kidneys look good as well. For those that don't know, have a look at the renal fat. Make sure that you can see renal fat. If you can't, then you may be looking at some sort of obstruction. But they actually look okay. So the kidneys don't look like they're stranded. And we're here anyway. Have a look at the adrenals, and the spleen looks good as well. So these are the times you think, all right, fine, I just have to do the long thing and go all the way down to the end of the bowel. So let's go to the bowel. Hopefully the images would have loaded up. So you can do a scroll all the way through and just make sure you haven't seen anything. Okay, so fine, let's have a look. So, okay, one of the things we noticed that they've got these inguinal hernias here, but do they contain any bowel? Doesn't look like it. So they just look like they've got a bit of fat. So that's not going to be the cause of the pain. But yeah, they do have a hernia. But yeah, I mean, they do have hernias, but they don't have anything going in there to be inflamed or anything like that. So let's start from here. Rectum, all the way around, bit of fecal loading, sigmoid colon. We're coming up this way, across this way. I think we're okay. Coming up here, here. Okay, we're coming up to the descending colon, splenic flexure, transverse colon, all the way across, all the way across. Looks okay, looks okay. Okay, we've come to the hepatic flexure, coming all the way down, all the way down. Let's see if we can find, okay, so around here it looks a bit weird, doesn't it? Like could be some fat there. Fat here we go. Some fat here, so that's going to be the ileocecal valve. So anything coming out there is going to be the terminal ileum. So that looks okay. See if we can find the appendix. So that must be the appendix there, that thing there. Let's see, does that blind end? Yeah, it kind of feels like it does that way, doesn't it? Going that way, and comes up to here. So that's going to be, is that the appendix? Yeah, it is. So the appendix looks okay, actually. So we haven't seen appendicitis, we haven't seen diverticulitis. Okay, so what else can be causing pain in a patient? So we've done cholecystitis, we've done pancreatitis, no renal tract obstruction. Let's have a look. So, all right, so there is some fat stranding over here. Can you see just there, a bit of fat stranding, a bit of fat stranding there. So let's have a zoom in and have a look what's going on here. So that looks like, yeah, it's located right in that sort of left iliac fossa region. And as you kind of come up, you can see that this looks a kind of hyperdense sort of circle and a hyperdense central area as well. And then it sort of disappears and comes again. Can you see that? And it's just really located on the anti-mesenteric side. So that's exactly what it is. People have done it. So well done. So that is actually epiploic appendigitis. So you've got the appendages that kind of hold onto the bowel, and they can infarct and they can end up resulting in pain, which can mimic diverticulitis and all sorts of other things. It can look like this. And I'm not can. It does look like this. And what can happen is that you just normally leave it, and then you don't really need to go in and do anything. And over time, it may calcify and just become like a calcified bit of hardness sitting on the antimesenteric side. And you may see remnants of previous epiploic appendigitis. But that's a nice little case. You can see how it's circular and a hyperdense center to that as well. And so that's how you kind of work your way towards figuring out what this person's cause of pain is. Okay, so good. Yeah, that's really good. Well done. So let's go to this one. Why did I put this one up? Let's see. Another CT head becoming neuro. Okay, so, oh yeah, maybe. Okay, what we'll do, we'll put this onto one by one. It's just easier. So that's the scanogram. Not particularly worried about the scanogram. We're waiting for the images to download. How do you differentiate a mental infarction? You know what? So a mental infarctions, in my experience, are usually a lot bigger than that. So a mental infarction, it looks like a collection, but it's like very sort of fat density in the center of it and normally quite big. And when I've seen it in my personal practice, it's usually been like post-surgery, something like that. Whereas when you see epiploic appendigitis, it just tends to be smaller on the antimesenteric side, usually around the sigmoid colon, left iliac fossa area. But I have seen it in other areas as well. But I'm just, generally speaking, I think classically they'll turn up with left iliac fossa pain. Sometimes I think they have a history of like sudden, they're trying to do some sort of exercise regime. They're doing a lot of exercise recently. That can be one of the soft causes for it. But yeah, proper mental infarcts, in my experience, have been a lot bigger than that in my experience. Cool. So let's have a look. And oh yeah, and so yeah, if you ever see what I just showed you, that's almost like barn door. Like you're pretty much not going to go wrong with epiploic appendigitis on that. Okay, let's scroll through this one. So we've got a CT head. I'm going to just say it was trauma. And let's scroll through. Keep scrolling through, keep scrolling through, keep scrolling through. Okay, so what's going on here? Okay, so we have got a CT head of this adult patient, and on first scroll through, it didn't look like there was much going on. So I'm going to scroll through one more time just to see what's happening. So what I'm looking for, you've got the kind of gyri, they will look okay. I mean, I know around here it doesn't look as obvious, but definitely when you come to the vertex, it looks like it's all right. So I don't think we're looking at like a diffuse cerebral edema. And if you guys are doing exams, I've noticed that when I'm teaching candidates for the 2B exams in particular, they like as a fail-safe that goes cerebral edema if they don't know. But I would say if you're 100% sure it's cerebral edema, then go for it. If you're not, then don't go for it. Really don't go for it. So yeah, so left cheek, yeah, it doesn't look quite right, does it? Okay, fine. So we'll have a closer look there. But the brain parenchyma looks okay. The kind of foramen magnum looks okay. There's no midline shift. So yeah, let's have a look closer at that eye region over there. So we saw, so someone mentioned, and they're right, there's a bit of soft tissue thickening overlying this sort of cheek area around the nasal area. So it looks like a hematoma, like maybe they'd been hit on the face somehow. So let's have a look at this. And actually, when you look at those nasal bones, they don't look quite right, do they? Let's have a look at the bone windows. Let's go to the bone windows, have a look at their nasal bones. They look like they've been fractured. So they've maybe been thumped in the face or something. Okay, so then if they've been hit around here, be very, very careful. We've got to look at the entire sort of maxillary sinus walls, make sure they all are okay as well. You can get a bit of mucosal thickening, but it doesn't look like fluid. So I don't think we're looking at a fracture. One of the other things you want to do is make sure you have a look at the zygomatic arches because they are very commonly fractured. Look at the mandibles. The number of times you get like mandibular fractures missed on these things. So just be very, very careful. Have a look. Still haven't seen anything grossly abnormal here. So what we'll do, let's try this missed oblique thing because that can be quite useful to try and see what's going on. So while that loads up, what I do, so when I'm looking for sort of facial bone fractures, I'll come down to, let's say, the eye over here, and we're going to be concentrating on the left one. So I try and align everything to be in line with the eye like this, you see? And that I find really useful because when you take this to full screen, you should be able to kind of scroll through and have a really good look at that sort of maxillary sinus wall, the orbital floor. And actually, that all looks okay, doesn't it? It doesn't look like there's anything grossly abnormal. So we've got, okay, so what we could do is say, look, this person, they've been hit in the face, most likely, they've got broken nasal bones and they've got a bit of mucosal thickening located within the, um, the left maxillary sinus. And yeah, I think we're good, aren't we? We can just let them go. But can anyone else see anything else going on in this particular X-ray or this particular scan? So let's have a closer look. Anyone can see anything. So what I'll do is let's go to lung windows. Maybe that will help. Should see a dentist. Yeah. Yeah, that's true. Okay, so okay, when I go to lung windows, can everyone see that? That doesn't look quite right. There's a little kind of dot there, right dot right there. So that doesn't look quite right. So is it fat? I mean, it could be fat because we did see those fat densities earlier, but it doesn't look quite right. There's nothing in that sort of suprasellar region. So this could be pneumocephalus. This could be pneumocephalus. But then why have they got pneumocephalus sitting there? So let's go back to the bone windows. And it does feel like there could be a bit of a kind of dip there, doesn't it? And so I'm sure I've done this for you guys before, but I'm going to do it again because I think it's such a good way to find these things. So go to MIP and go to like, 30, 40, something like that. Then you just sort of window it a bit like this and then come forwards, forwards, forwards. And then what you can do is come to that area that we're looking at and just sort of angle it a bit. Can you see that? There's like a dip right there. So they've actually been stabbed in the head. So someone came in and was attacking them. They must have had a bit of an altercation. They broke their nose, as you can see, a few broken nasal bones, but they've actually got a bit of a dent there. So I think the knife did actually go and puncture that area there. So now we know there's a fracture there. We've got to be really, really careful and make sure we haven't missed some sort of subtle bleed in that area. And amazingly, I think what we have is just a bit of loculus of air, but I don't think we can see a bleed anywhere at all, which is actually really remarkable considering they've been stabbed in the head and then end up having a fracture. So yeah, a combination of things, but really, really important that you do reconstructions, have a look, and yeah, the 3D recons. Honestly, the number of fractures I picked up doing that 3D recon, because I know that people love these 3D recons where you press a button, it does it, but genuinely, sometimes it just smooths it over. And the 3D recons you do with MIPS and the kind of windowing can really, really bring out really subtle fractures. So I'd highly, highly, highly recommend doing it that way if you can. Okay, let's have a look at that next one. Okay, so let's have a look at this one. So we are looking at well, okay, quite a lot of cases. So what we'll do, we'll just download all of them. Um, let's do this. Let's do this. So download, 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 download. So let's have a look at this one here first. So I think there was a poll question to this one, maybe. Well, we can do the poll as well while and just keep the poll open, maybe, just because we haven't even been able to go through the cases just yet. Gives you clues to what it could be, though. Fine. So why is it not opening up? Let's try this one. What else have I got? I've got an MR and I've got a spine. Okay. So let's have a look at this chest X-ray whenever it pops up. No. Okay, what else do I have? I've got MR, I've got CT. Oh, there's CT here as well. Okay, let's do CT. KUB. Right. Okay, so this person comes in with abdominal pain. Let's do this. Let's rotate round. And so we know this is CT KUB because of the fact that the table is over here and they're lying on their front over here like this, right? So I've turned it around to make things easier for me. We know it's a non-contrast study as well. So it's a non-contrast study here as well. Good. So what do we see here? So let's come to the very, very top. And when we do these scans, these CTKBs, we're looking for renal tract obstruction. So actually, when you look at that right side, that doesn't look quite right. You can see a lot of renal fat here, but maybe not as much renal fat here. So is this obstruction? So that's the ureter going down that way. Can be quite difficult to follow, but we're coming down, we're coming down, we're coming down. I feel like there's somewhere around here, coming down, coming down. And actually, can you see that ureter's going this way? And just sitting there is a calculus located there. So this is interesting because this is actually a vesico-ureteric junction calculus because if this stone is just free within the urinary bladder and they're lying on the front, this would fall forwards, wouldn't it? But it's stuck there. It's not moving. So therefore it must be stuck. It's actually stuck right at the vestibular junction. So that's good. Okay, so what else have we got here? So that's fine. I mean, we could just move on. Say this person has got, multiple renal stones, a bit of a renal calculi former, and they've got a obstructing right renal stone, and they may need to go to urologist and that kind of thing. But then when you do look at everything else, you look at the liver. Okay, so the liver looks all right, I guess. Look at the gallbladder, looks okay. Pancreas is a bit difficult to see. Spleen looks okay, and let's have a look at the bowel just to make sure there's nothing going on. It was a bit difficult to follow. So if you are finding it difficult to follow the bowel, I always go for my constants, which are going to be the descending colon, and then work my way down. And that usually will bring me back to where I need to be. And that looks like it's done the trick. Okay, so it looks like we veered off this way, haven't we? This way, this way, this way, this way, this way, this way. So splenic flexure across the front, across the front, across the front, like so, across to these hepatic flexure, all the way down. Yeah, I don't think I'm going to. I mean, well, yeah, I reckon you can see the appendix. It's probably just there. Can be small though. It'd be hard to see in a non-contrast study, but I think we're doing okay. Oh, someone said, never seen that word before. Morbus, what is that? Morbus Bectru. I don't know that. I'll look it up or tell me. So then we have a look at the rest of it. And actually, when you look at the sacroiliac joints, they don't look quite right, do they? They look like they kind of look like partially ankylosed. There's something going on there. Coming up to the oh, is that what that is? Okay, never heard that phrase before. Okay, cool. So then you've got sacroiliac look, the facet joints, they all look very, very sort of ankylosed, completely ankylosed, don't they? So this person's got a background of ankylosing spondylitis as well. And the reason why I think it's important that I bring it up is because sometimes this is the first time they turn up. They've been having pain for ages, don't know what it is, having painkillers for a long, long time. And then they come in and then, they come in, get these scans, and we don't quite notice the fact that they've got underlying ankylosing spondylitis. And if they're treated quickly enough, then they can actually have pretty decent outcomes. So I wanted to just make sure that let's go to this one and just have a look. Oh, done this again, isn't it? Let's go one screen layout one and just have a make sure that there's no like avascular necrosis of the femoral heads or anything fancy like that. But yeah, it does look like there's definitely ankylosing spondylitis. So then we do have a chest X-ray, and it is important just to have a look at the apices, make sure there's no apical fibrosis, because you can imagine they're kind of stooped over like this. The apices are not going to be as aerated as you'd otherwise expect, and you can end up getting apical fibrosis. Doesn't look like that's going on here. We do have a lumbar spine. Lumbar spine does look very straight, doesn't it? It looks very, very straight. It normally gets sort of a lordosis, but that could just be the way they are. When you look at these facet joints, can you see how there's not much in the way of any synovial fluid sitting there? Remember, this is sort of a T2 weighted image, fluid there. You should really get a little bit of fluid there, but just isn't. Most of it's sort of ankylosed, stuck together, stuck together, stuck together. Do we have any more? Let's see here. Yeah, you can see like how completely ankylosed all of this is. So this is very important as well. So you always have to look. And actually, I have been caught out once from this, and I just want to make sure that no one else gets caught out by this. If you go to the CT scan again, where's the CT? Have I lost the CT scan? Always do this on the CT scan. Look at the sagittal views and make sure there's no fracture, because there was once where it was a KB. Yeah, and then it turned out there was a fracture across there, across there, and across there, which had initially been missed and picked up pretty soon afterwards. So very, very important. Once you picked up ankylosing spondylitis, you've got to go for like the big thing, which can be, potential fracture. There's always a risk. So just have a look and make sure that you've had a look and seen it, or have a look around and see if there is one. Okay, so let's have a look at which one is this one. Hang on. What did I just click on? Chest X-ray. You know what? I'm going to come back to that one, and that will make sense in a minute or two. Okay, so we are going to jump ahead to case number 9, and there is a bit of a quiz thing to this one. And this looks like we're looking at the facial bones, like an OM view. You're kind of looking at an angle, trying to look at the cheekbones, look at the face, and that kind of thing. And we have a look at so make sure there's no eyebrow sign. I mean, it's not particularly projecting well, but eyebrow, yeah, I don't think there's an eyebrow sign there at all. There's a maxillary sinuses. How do they look? So that looks like it's okay, but this one looks a little bit pacified. Doesn't look quite right to me. Okay, fine. Let's look at the elephant. So this, for those that don't know, when you draw the zygomatic arch, it's meant to look like a bit of an elephant, right? So that looks like the elephant arch is okay. This other side doesn't look quite right. Look, you see that? It kind of folds in that way and then comes out that way. So that doesn't look quite right either. Let's zoom in a bit and see if we can make a bit of sense of what's going on. So that lateral maxillary sinus wall kind of looks like it could be a bit unusual and looks slightly pacified to me. But without a doubt, that zygomatic arch looks like there's a break there. That poor elephant's broken their trunk and is kind of stuck in the middle there. So what it looks like here, but we actually, so what we need to do is sort of zoom out again and just make sure, because sometimes you may see like a bit of a teardrop sign here. And I think it'd be very difficult on the quality of X-ray here, but I just wonder whether there could be a bit of increased soft tissue density. Okay, yeah. So this is the thing from the last one. It just popped up now. I made up this one, increased risk of HCC. I don't think that's associated with ankylosing spondylitis, but the rest of them are associated with ankylosing spondylitis. Apparently, with ankylosing spondylitis, you get inflammation of the aorta, and over time you can get sort of aortic stenosis, which is quite interesting, I guess. Okay, so yeah, we have got a fracture of the zygoma, and I am a bit worried about this. So what I'll do is end up getting a facial CT scan to kind of characterize things a little bit more. Yeah, a bit of a riddle. Why is it this side? So this is the left side. Why is it the left side? Yeah, exactly. Most people are right-handed. So when they go and punch someone in the face, I'm not saying, and I'm not accusing anyone of punching anyone in this particular situation, but it just so happens that a lot of facial fractures end up being on the left side. Make your own decisions as to how that happened in the first place. I don't know. Do you guys still get the punch the wall kind of thing? You know, they come in and say they punched a wall, and you think, all right, I mean, if you say so, I mean, it could happen. I'm not saying it couldn't, but it could happen. Right. So yeah, but I think most people got that little kind of riddle. Cool, cool. So yeah, most people are right-handed. Fine. So let's have a look at this one. And the follow-up is going to be one that I skipped earlier. So then that will make sense as we go through it. So this looks, let's say trauma, and we're doing a follow-up scan. And because I think the person's GCS was dropping. I think that's what it was. And let's have a look through. So let's scroll to the very, very top once we are ready. How did you get an umlaut on the U so easy? Okay, so let's go from the very, very top. Okay, so first off, does it look asymmetrical? Yeah. Okay, so look at those CSF spaces there. That looks normal, but that one doesn't look so normal. The CSF spaces are gone here. So you're thinking there could be a bit of edema here. Okay, so definitely some edema. And as you come further down, there is some hyperdensity located within this region over here. And you've got a bit of a hyperdensity located within this region over here. Good. And you've got a big, big bump over here. So you've got subcutaneous hematoma, and you've got what looks like a subdural hematoma over this region, kind of going this way, this way, this way. Coming further down, though, you've actually got more kind of linear bleeds located within the region of hypodensity. So you're probably looking at sort of a contusion bleed there. So you've got subdural bleeds and contusion bleeds there. Still a bit of subdural bleed going further down. Coming further down, a bit more subdural. Looks very, very crescenteric as you come further down. Bit more subdural blood located within this region. Bit more subdural blood located within this region. And actually, when you come out down to the temporal lobes, you've got to be really, really careful just to see, because acceleration, deceleration injuries can result in contusion injuries located within the anterior aspects of the temporal bones, because your brain kind of goes forward, 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 hits the front, and ends up getting more bleeds. So this one, I don't think I can convincingly say I can see any more contusions. Very, very important we look at the other side just to make sure there's no other bleeds anywhere else. Come to the top here, it does look like some of this is quite linear, actually, doesn't it? Like, could be a bit linear. So there could be a potential combination of a few bleeds. You've got contusions, contracus, subdural, maybe a potential small subarachnoid as well. Midline shift, yeah, I think there might be. This looks like it's slightly towards the left, isn't it? Because if you draw a line like that, it's slightly towards the left, so that's something to worry about. Sometimes with significant bleed, you can get secondary ischemias as well. Yeah, someone's picked it up. Okay, good. So well done. So that's fine. So we've done that. Good. Foramen magnum looks okay. And then let's have a look at the bones. Let's have a look at the bones. Make sure, can we see any fractures anywhere? So let's go from the top. Okay, so we've got a sort of a shunt in situ, so that's good news. Probably going to help them, hopefully. Scrolling through, scrolling through. So we had the injury over here, wasn't it? Or was it around the back? It was around the back. That's where the hematoma is. And there does look like there could be something that's not a suture there. Can you see that going all the way across like that? So that's not great. Looks going all the way across like so, all the way down to here, maybe all the way down here as well. Um, so does everyone make an additional CTA for quadrisection with these fractures? It depends on your risk, how risky you think it is, and whether there's a fracture of the C-spine, which may be causing, there could be a potential area of fracture. If you think there could be a potential vascular injury, this one, I don't think I could 100% say, actually, you know what, there is a fracture there. Can you see that? I'm going to zoom in a bit. You know what? I'm going to do what I showed you guys. Let's do this. Let's go to, oops, go to one and let's go MIP. Let's go to like 30, 40. Let's window it a bit. Let's have a look. Can we see the fractures? Let's window a little bit more. Window this one a little bit more. Okay, look, yeah, that looks like a fracture, doesn't it? Going across like this, all the way down like that. Does it go anywhere else? So what you can do is if you keep your eyes on there, you can actually turn things around as you go like this, and then just sort of have a really good look around like this. Can you see that? Like that. So this fracture looks like goes along like this way, this way. There's maybe a bit of dehiscence and a bit more of a fracture that goes down this way as well. And then you can sort of turn it around some more and come up to this area over here because I was concerned there could be more of a fracture. Can you see that on the floor? So what we'll do, we'll zoom in, and then I'm going to draw it for you guys. Can you see a fracture going like this, like this, like this, like this, all the way along like this? And it looks like it goes along the roof of the sphenoid, doesn't it? So let's come up to here, see if we can find it again. So that's there. Yeah, can you see that there? So we've come up to this region. You can see fracture line going like this way, this way, this way, this way, this way, this way. Kind of, well, it's going all the way that way as well, isn't it? Can't really see where it goes on from there. So quite extensive fractures, right? So really, really big amount of fractures. You got a fracture along the skull base, which is going along the roof of the sorry, sphenoid, too much MSK. And then you've got a fracture that's going along the left parietal bone. It looks like it may extend it into the sutures as well. So the bit of like your sutures are like jigsaw puzzles like this. And so if you see sutures, they should be like that. If they're flat lines, then it's a fracture. But sometimes they can be pulled apart a bit. And I do feel like when we went along this way, that suture line at the bottom there didn't look quite right. It looks like it's slightly widened. Can you see that? So I think there's a fracture going through the suture area there. So there's definitely quite an extensive fracture on that side. So we've got bleeds, we've got suture, we've got bleeds, we've got fractures, quite extensive fractures, subdural, contracture, and a contusion. And actually, yeah, and people have been really smart. They picked it up already, haven't you? Can you see this? What's going on here? So it's really, really important to check all your lines, right? Just like with the chest X-ray, look at all the lines. So this line here, look at it, it's kind of doing this, kind of what, curling around like this, curling around like this, curling around like this, curling around like this. Doesn't look quite right, does it? Looks very, very weird. So, and then you've got your airway adjunct over here, isn't it? That's the airway adjunct, which is separate. But that line is all curled up and completely, completely weird. So then what you need to do is come across back to case number 8, which I think was the X-ray of said person. Let's get it out, open. What have I done? Let's come back to case number 8 and open it up. So obviously, like, I'm not saying it's a great situation for the patient, right? I mean, they've got significant fractures and all the rest of it. But now look, he's ET tube, the airway adjunct over there, but that's the end of the NG tube. Can you see that? Let's zoom in. Right there. So that should be in the stomach, not all the way up there. And the reason that's happened is because it's kind of curled in the mouth and gone all the way down. But yeah, so yeah, it's a brave place to put it. Yeah, yeah, you're right. So someone said brave place because of the sphenoid fracture. But yeah, look, you can see there's quite that the NG tube is incorrectly placed. And I remember this case because that was exactly how it got picked up. It was picked up on the CT head that the NG tube was incorrectly placed. And then we went back to the X-ray and saw that this was actually incorrect in terms of, yeah, I mean, sitting all the way up there. So, you know, unfortunately, the patient's got subdural bleeds, subarachnoid bleeds. They've got ET tube, you know, they've got the ET tube correctly placed. And you're trying to work on the bigger problems. And as you saw, we had to do a fair bit of work to find all the potential fractures, characterize the fractures. And then you may miss that like one bit that could be the next potential problem for the patient, right? Like if they try and feed the person and they end up aspirating, then they're gonna end up having actually, and you know what? You do wonder, don't you, whether that may be exactly what happened. But anyway, let's have a look. I think that might be it. I don't think I had any questions for that one. Let's have a look. Yeah, that's it, I think. Cool. So, in summary, I hope that was useful. I hope that you guys have taken on the MIPing thing. I have genuinely found so many Fractures that I may not have seen easily using the using that MIPPing method, the windowing method, go to like MIP of 30, 35, something like that, and window until you can see it. And from that case that we showed you earlier, the NG tube being in the wrong place, definitely always look at like the final bits. Make sure you know which line is what, why they're there, and are they correctly placed. And in that occasion, and it's not the only occasion actually, but this is one of the occasions where the NG tube was incorrectly placed. Cool. I don't see any questions, so I think we are okay. Cool. Yeah. So thank you guys. As always, I mean, I can't believe we've been doing this for 24 months. That's 2 years, guys. Honestly, that is completely crazy. And I still remember the first time I did, I mean, I still get nervous every time I do these. Genuinely, I really stress out. But the main thing is you guys find it useful and the feedback's always been good. So please do give good or bad feedback. I don't mind. Genuinely, I keep saying it every single time. Give me bad feedback if you want, because it actually helps me get better. I want to be the best teacher that I can be. So I really appreciate it. And I hope that some of the teaching that I give you, you may be able to take forward and help people in your practice. So I think that's it for me. I'll see you next month. All right then. Bye.
Thank you so much, Imran. Another great webinar. I'm just posting a link to the survey. Please do fill in that survey. Your feedback's very much appreciated, and we can generate those CPD certificates for you. If you do want to donate any cases for the next month's webinar, simply upload a case to the global community, and what you need to do is just tag Dr. Imran Lasker into that case. So it's at DOCLASKER, so at Doc Lasker. He'll be able to review that case and potentially go through it in the next webinar. If you have any questions as to how to upload the case, just contact us via support@cmrad.com, and that would be great. So I'll leave that link there for a few minutes.